Well, greetings everyone. Thank you very much for joining our webinar today. It's my great pleasure to open the discussion, which will feature two incredible women, Dr. Mona El-Shokry from Egypt and Miss Kadiatou Dao from Mali. We were fortunate to have known both of them since 2015 when they came to our center as visiting fellows programs, and they received Robin Copeland Memorial Fellowship stipend to be able to receive training on general non-proliferation related issues. And since that time, we were in touch with one another, and now that we all face them so they could share their views and perspectives of how their countries respond to the pandemic. And before I give a floor to my other colleague, I would like to thank CRDF Global, who've been very great in cooperating with us and sending these incredible women to our center. And without further ado, I would like to introduce Dr. Richard Pilch, who directs our chemical and biological weapons non-proliferation program. Please.
Thanks, Margarita. Well, it's an honor, of course, to be asked to provide some introductory remarks for today's talk. You know, I think when this is all over, and we're going back and trying to understand what happened specifically in the US with this pandemic, I would bet that the key finding will be that we lacked a central coordinating authority that owned the US response. And whether we talk about shortfalls in testing or shortfalls in contact tracing or unclear risk communication, whether we should wear masks, whether we should social distance at a certain, certain distance, whether we should close our borders, all of those things, feed back into the fact that we didn't really have that central authority that we need. And I think that's a lesson that translates to the global level. Whether we're talking about US states or nations that are part of a global community, we need this, this sense of oneness and the ability to support each other through a central coordinating body. I think probably everyone on this call knows that earlier this month, the United States announced that it will withdraw from the World Health Organization. That decision can be changed and it's not effective until next year, but my talking point to that would be that simply it goes against everything we've learned in the past 6 months. The World Health Organization isn't perfect. I mean, I think it's unrealistic to expect it to be. It has one of the most complex and challenging jobs there is. Like us, like the United States, and like every country around the world, they are learning from this, and they will go back after the fact and see all the things that could have been done better and learn from that and improve. But I think I can relate a story that to me shows really the value. In 2006, we were worried about a different pandemic. We were worried about avian influenza H5N1. So H5N1 is a type of influenza that is widespread in birds. And when it infected people, it had devastating effects. So the big concern was always that it would adapt through mutation to be able to spread among people very well, like COVID-19 does, but with a much higher lethality and create sort of the nightmare pandemic that we had been worried about all along and are now, to some degree experiencing. In around February 2006, there was a small town in Azerbaijan, which is a country in the former Soviet Union, the Caucasus area. It's bordered by the Caspian Sea on the east, Armenia on the west, north is Russia, south is Iran. And in this small town, there was a cluster of human cases of H5N1 influenza, which in and of itself isn't too alarming. It just means that people were exposed to infected birds and probably got sick. But then what happened is a few days later, in time with transmission dynamics and expected incubation periods, there was a second spike in the epidemiological curve that alarmed the global community that we might be seeing person-to-person spread. So effectively, the entire world descended on this country the size of Maine and tried to figure out how we're going to solve this problem. I was sent there on behalf of the US Department of Defense. There were other US agencies there, the CDC and USAID. And even the three of us really couldn't figure out how to work together to deal with this concern. The government of Azerbaijan, of course, hosted us. They had multiple ministries involved: Ministry of Health, Ministry of Agriculture, Ministry of Emergency Situations. Then the international community was there. WHO was there, UNICEF was there, OIE was there, foundations were there, Rostropovich Foundation, others. The bordering countries were there, Iran, Russia. The oil community was there, BP, because they were heavily invested in Azerbaijan's oil trade. And all of us were bouncing off each other, trying to deal with this, potentially massive problem. And it was the WHO that brought us all together. They had a local office there, and we all went in. I mean, people that you would not expect in one room together. And we sat down and we figured out how to coordinate our efforts, how to coordinate our investments, how to make sure our case definitions align, how to make sure, the pipette tips that one company bought or one organization bought fit the pipetters that, World Bank was providing. World Bank, another big player in all of this. So that to me is sort of exemplary of the value of the WHO. They are a unifying body, and certainly not something that any country can afford to be without, U.S. or otherwise. I think we all would agree this pandemic is a change event, right? And I think the question is, how are we going to change after all this? In the US, will we become more nationalist, or will we recognize that the biggest challenges that the world faces today are global, and the only way we can address them is as a global community? I think that it's important for everyone to understand that the US just can't invest in everything, even the most meaningful initiatives. When I was preparing, these couple of minutes of talking, I went to double check how big our debt was, and our debt is $26.5 trillion, which is, actual debt that we owe creditors. And when I typed that in, and for the first time, it just sounds like a number to me, but for the first time I actually saw the number. It fills up the entire Google search window, says 17 numbers all the way across, right? It's huge. So, we are going to, as a country, as part of this global community, we are going to need to be careful about where we invest. But where we can always invest is in relationships. And the people that are tasked with addressing these global problems that affect us all. And whether that's through joint training or research collaboration or just sharing data, those are the things that I believe will get us through not only this crisis, but the crises to come. I think my final comment would be, and everyone on this call knows this because of our profession, but sometimes I have to remind myself, and more recently, every international threat, whether it's a pandemic or WMD or terrorism or natural disaster, it presents a challenge and an opportunity. The opportunity is to build bridges, to build trust, and to really build a better world. And it's programs like the one that enabled us to work with Mona and Katie, and programs like I've been lucky enough to work with many of you on this call on over the past couple of decades that give me hope that we will find a way to work together and realize that opportunity. So with that, I'll introduce our great speakers. I apologize, I'm going to read their introductions and probably butcher them. What we'll do is I'll introduce Mona and Katie, and then Mona will talk, and then Katie will talk. After that, my colleague Joe Luster from the Center for Nonproliferation Studies, who I'm fortunate enough to work with, and who incidentally grew up down the street from me in Rosemont, New Jersey, in a very small town with the state's only covered bridge. So I don't know how that happened. She will then take over after the two presentations and become the moderator, and we will receive questions from viewers, and our speakers will respond. As a reminder to everyone, our speakers are not speaking on behalf of their governments. We've asked them to share their experiences in their countries. So we will appreciate their candid responses and understand that it's in the context of an individual, sharing personal experiences. So to Mona and Katie, I'll read them both in succession and then turn it over to Mona. So Dr. Mona El-Shokry came to CNS under CRDF Global's Robin Copeland Memorial Fellowship in 2015. Her capstone project, integrating biosafety and biosecurity norms in routine activities of clinical hospital laboratories, led to the introduction of biosafety and biosecurity in clinical laboratories in Egypt. She currently directs the Medical Microbiology Research Laboratory and also serves as a mentor in CRDF Global's Women Advanced Chemical Security Mentorship Program 2020, guiding Iraqi scientists to develop capstone projects in the context of chemical security. Previously, Dr. El-Shokry served as a laboratory consultant at the WHO Regional Office in Cairo and as a clinical microbiologist at CDC's Global Disease Detection Center at NAMRU 3, if you guys know what that is. It's the U.S. Naval Medical Research Unit number 3, which is in Cairo, supporting the implementation of antimicrobial resistance surveillance. So Mona is wonderful. I've had the opportunity to work with her on other initiatives, and we look forward to her talk. I'll just introduce also Kadiatou Dao very briefly. Ms. Kadiatou Dao started working at the National Institute of Public Health as head of the unit in charge of molecular diagnostics for bacterial meningitis in 2008. She subsequently received scholarships to work in France. I'm jealous, where she received a master's degree in science and technology in 2013, and the US, where she received a certificate in non-proliferation and arms control, focused on biosecurity at CNS. Under, again, CRDF Global's Robin Copeland Memorial Fellowship in 2015. Her passion for strengthening Mali's laboratory networking and implementing international tools related to biosafety and biosecurity led to a key role in Mali's Ministry of Health and Public Hygiene Global Health Security Agenda implementation process, including participation in the International Health Regulation Joint External Evaluation and multi-sectoral One Health platform. Currently, she is the Security and Safety Assistant on Mali's National COVID-19 Crisis Committee. So again, thank you to our speakers. Thank you to CRDF Global for the opportunity for us to work with them through the fellowship program. And Mona, over to you.
Hello, everyone. Good morning, good evening, good afternoon. Assalamu alaikum. Thank you, Richard. Thank you, Margarita, Jill, and Joshua. I'm really super excited to be here with you in this webinar. It's been 5 years, and definitely working with you at CNS definitely impacted my entire career and opened a lot of doors to me. So I'm really grateful for the opportunity that CRDF Global granted to me. Now I'm going to share my screen to start my presentation. Okay, can you see the screen now? So, great, okay. So I'm going to talk today about Egypt experience during COVID-19 pandemic. And as Richard just mentioned, it's from my personal perspective. And there's some information I've already drawn from the governmental websites on the internet. We're going to talk about Egypt profiling and the COVID-19 timeline in Egypt, the implication of the pandemic and current status as of July 2020, and of course, lessons learned at the end of the presentation. So Egypt has a very strategic location. It's a continental country situated in Africa, in Northern Africa, and part of it is situated in the Western Asia, which is the Sinai Peninsula. The country has a coastline at the Mediterranean Sea in the north, which is considered for Egyptian is the summer getaway. And we have the Red Sea on the east, which is our winter getaway. So we're very lucky to have two seas. We have also maritime borders with Cyprus, Greece, Turkey, and Arabia. On the west side, there is Libya. On the south, there is Sudan. And we have also on the northeast, Israel and Gaza Strip. Egypt is divided into 27 governorates. The governor is appointed by the president of Egypt. And Egypt is the most populous country in the entire Middle East, and the second most populous country in Africa next to Nigeria. About 95% of the 8 million, of 100 million people as of February 2020, maybe they are 105 by now, live along the bank of the Nile and the delta of the Nile that looks like a V shape. 90% of the population is Muslim and 10% are Christians. This is some picture that depict the ancient Egypt that we all, maybe we mostly know about it. Egypt, the pyramids, the Sphinx, and the majestic pharaohs. And we no longer go to work by camels, by the way, because when I was in the US, I got this question so frequently. So we no longer go by camels, we commute by buses or private cars or public transportation. This is a view of the Nile, and this is the sleepless city of Cairo. And this is Hurghada, one of the international destinations for those who are in love with scuba diving. So these wordy slides describe the Egyptian diplomacy and international relations. To sum it up, we have, from my personal perspective, we have good relations with our neighboring country. And this is in line with the Egyptian Foreign Ministry policy and also Egyptian diplomacy policy, which seeks to maintain strong bilateral and multilateral relationship with their neighboring country. However, if you keep up with the international news, we have a slight tension with Ethiopia over the, what they call it, GERD, the Grand Ethiopian Renaissance Dam. This dam was constructed in 2011, and Egypt big fear is that would reduce the share of the Nile for Egyptian, and that would lead to the risk 2,000 acres of land to be out of production. Almost 500,000 of farmers would stop working, and consequently 2.5 million of families would be drawn into poverty. There is ongoing negotiation between the three parties, Egypt, Ethiopia, and Sudan. But till as of this moment, we haven't heard the result of these negotiations, and hopefully it will not drag us into a water war. I put this link for details on this subject matter. Regarding the health profile of Egypt, Egyptian healthcare system is pluralistic, which means that there is a variety of healthcare providers, the public, the governmental sector, and the private sector. For several decades, the government has provided a subsidized healthcare system that ensures healthcare for those who cannot afford it. And due to its pluralistic nature, healthcare providers from various sectors can compete, and the customer can have the freedom to choose which one to go for on the basis of the financial abilities. If I'm talking on a personal basis, we, as a middle class, we opt for the private sector. The quality of health services in the teaching university hospitals is very good and with affordable prices. But because of the cheap prices of the healthcare services provided, there's a long line of patients waiting to take an appointment to get their healthcare services. So as a middle class, we opt for the private hospital and private clinics, and we kind of covered up by the insurance companies. In general, the fees for the healthcare services provided in Egypt is very cheap compared to other countries. And I'm saying this because I have my brother and sister living overseas, and when they want to go for any dental or surgical procedure, they prefer to come to Egypt because they have affordable price with good quality services. And of course, with any system, the healthcare system has many challenges. But with the current pandemic, it drew the attention to the need of more reform of the healthcare system and more budget to be allocated to improve the healthcare services. When we come to the burden of the diseases, the communicable diseases, for example, like hepatitis or influenza or typhoid or meningitis, it's accounted for 10.7%, while non-communicable diseases account for 84.7%. Non-communicable disease, for example, heart diseases or diabetes. Egypt is known to be endemic for viral hepatitis C and avian influenza. And actually, we have a very, very success story about the strategies to eliminate Egypt from the hepatitis C virus. Egypt managed to get the therapy for hepatitis C with very, very affordable prices. And alongside with a campaign to screen Egyptians in all 27 governorates, and those who tested positive for hepatitis C were registered to receive the treatment with very cheap prices. The success story, which we're all proud of, are also provided here with more details in the link in this slide. So let's go serious with the pandemic. And this is a timeline of the healthcare system preparedness and governance in Egypt in 15 days, starting from patient zero. This was in February 14th, and the March 8th was the first COVID fatality recorded in Egypt. In March 11, WHO declared coronavirus as a pandemic. And from this point on, each country adopted a different approach. And the approach each country adopted reflected on how much time they needed to contain or circumvent the pandemic. So from this point, we share in this date with all other countries, but then what comes next is different with each country strategies. For me, March 14 was a very important date because this is the date of suspension of educational facility operation. I'm teaching in the medical school, Ain Shams University, and as you know, for medical students, the teaching is a mix of theoretical and also technical skills. So it was very confusing for us how to deliver the educational materials online without the need to go to the lab or to see the patients. So it was a bit a challenge for us, but the leadership and actually the management made it a little bit successful to compromise certain things because we are all facing unprecedented events. So we need to compromise the technical part, but we started to shift to the online teaching. And I'm sure this pandemic has taught us that we need to have a contingency plan in place so that when there is any emergency, we can just shift in no time with our work to be remotely conducted. In March 19th, there was a special aviation and there was so many people stranded in different countries, and the government made efforts to operate special commercial flights to repatriate those suspended families and workers. So you have to consider that I'm a microbiologist talking economy, but I think that's what I learned at MIIS, that you need to go beyond the comfort zone of your expertise. So as in other countries, Egypt's economy is being impacted because, of course, of excessive resources that has been consumed in the containment measure, as well as the sudden stop in the tourism, the export, remittances, and lower revenues from Suez Canal that connect the Mediterranean Sea with the Red Sea. Of course, the unemployed, the working class, the small businesses were hit the hardest. Many businesses have been shut down, but some businesses actually were very smart to adapt to the new situation and turn their business into the online, and they made a great profit out of it. In Egypt, online shopping is not that popular like in US. We tend to go to the malls, window shopping, pick our own things. So we're not really, the online shopping was before the pandemic was not trustworthy. But during the pandemic, there was huge change in the dynamics of shopping in Egypt, and people start to click the button to place their orders and get their the items through online. So I think this also another change of the e-commerce where everybody is now shifting to the online shopping. When it comes to the implication of the health system, of course, there was, at the beginning, there was a slight confusion. There was a lot of overwhelmed staff with the upsurging of cases. However, the Ministry of Health and Population start to scale up the necessity to cope with the needs for healthcare system. So there was 27 quarantine specialized hospital in each governorate for patients infected with COVID-19. There was a hotline and WhatsApp number was provided by Ministry of Health and Population for those who have any queries and would like to have any guidance. At the start of the pandemic, we had a test PCR for patients only at Central Public Health Laboratory, and the kits were supported by WHO. There was a mandatory almost 14 to 28 days isolation for any person comes from any foreign country. And of course, healthcare workers were also were always praised by the government, and they were called the White Army to upload their work and dedication during the time of pandemic. So there was actually, and I wanted to be in line with what Richard has said in the introduction, WHO is doing actually a great work on the ground in respect to the pandemic. And I have to say that there was a technical mission at the start of the pandemic to assess the technical capacity of laboratories. And they stated that they need more to be done to improve the capacity of laboratories and to be able to cope with the needs for testing. One thing that always misunderstood by the public regarding the responsibility of WHO. I joined WHO for 2 years from 2017 to 2019. And the first thing they taught me there, or I learned, that we are the secretariat of the countries or the member states. And a secretariat means that we are going to a review mission or technical assessment mission or assessment mission in general. We only provide recommendation. We cannot force the country to follow our guidance or our recommendation. The country has the total right to accept all these recommendations or just decline it. The misconception comes from people think that WHO should have done this, should have forced the government to do so. And so there was a little bit of anger on the social media circulating. Why didn't WHO force the country for a full lockdown instead of partial lockdown? But as I explained here, the WHO has no right to force any measures on the country. One thing during the pandemic that WHO has gained a lot of visibility during the pandemic. Actually, they've done, and I want to commend the great work. They have on their site an up-to-date guidance on how to disinfect different materials, how to deal with patients, how to isolate the patients at home. And even when there is a rumor circulating in the on the social media, I can find some sort of explanation on their website. So it was easy for me at this point that if anyone have any question, just to send them the link of the WHO website to give them the clear answer. And it was in Arabic and it was in simple, non-scientific language. So it was easy for people, general public with no scientific background to follow in this. Before that time, and personally, I didn't know that WHO has more work than just vaccine campaigns. But when I joined, I found out there is a mine of wonderful resources at their website. And I hope this pandemic would also draw the attention to the more work that WHO is doing. And with joint effort with Ministry of Health and Population, Ministry of Health and Population was following their guidance and keep updating the protocol for treatment, especially for those who are treating themselves at home. So from economic perspective, I'm sure that everything was affected, but I would say with controlling the outbreak, and I will tell you why I said controlling the outbreak, because we are in the stage of the outbreak control based on the number of cases. So this drew the attention to certain sector that actually was overlooked before. One of them was the healthcare system. And so there was more allocation of the budget to serve the healthcare facility and to provide the needs for PPEs and the equipment and so forth. In terms of agriculture, there is financing of the purchase of local wheat from local farmers, and there was urgent commodity and service need in the month of January, and they start to increase the budget for this to meet the needs for that. In terms of the healthcare perspective, as I mentioned at the early of the pandemic, it was only the Central Public Health Lab who was entitled to do the testing for COVID-19. But with the upsurging of cases, it was almost impossible to rely on one lab to test for all patients need to be confirmed with the lab testing. So joined by other laboratories, about 27 laboratories across the country also were testing patients for COVID-19. And as you see here in the picture, there was also drive-through checkpoint center where you can be in your car, get the swab from your throat, the result in an hour or maybe a day, and then the result will send to you on your WhatsApp number. The testing, of course, has been increased with the upsurging of cases, and there was a scaling up of the infection control and infection prevention control practices in joint effort with WHO to respond to the high death rate between among the healthcare workers, doctors and nurses, which reached up to 7%. There was also expansion in the number of the hospitals that serve the patients. And this picture, if you can see it clearly, this is one of the field hospitals of my university, Ain Shams University, that was equipped with 2,000 beds, 1,000 ICU beds, and 400 ventilators. So what is the current situation now in Egypt as of July 13th? So as you can see here, I'm not sure if it's clear to you, but the upsurge of the cases, or the peak of our curve, was actually in June, in June 19th. So where the cases reached up to 1,700. This was the peak of the highest rate of infections during the pandemic. And after that, not sure if you can see it, but after that, they start to be dropping in the number of cases. It was 912 in July 13. Yesterday was 930, and we're expecting kind of stability in the curve if it's not going to if we're not going to be down. The total number of cases is around 82,000. And the highest number of cases are in Cairo, Giza, Qalyubia, and Fayum, which are the biggest city in Egypt. And there was 55% of males and 45% of females were infected by COVID-19. Now, what's going on the social media also, that we are not sure that these numbers are true numbers. Why? Because simply this only the numbers that represent those who come to public health laboratories to get tested for PCR. And while we have patients who are only diagnosed clinically that are not in this count, we have those who are asymptomatic, they don't know that they are infected, and we have those that they are self-isolating at home because they have mild or moderate symptoms. So how come we trust this number? I'll tell you why. We still can rely on this number to reflect the situation in Egypt, because even if the number does not reflect the real number, but at least it signifies that there is reduction in those who come to testing and get positive results. So I don't care if this number is not a real number, but I only care that there is a sort of hope that there is a decrease in the number of infected cases with COVID-19. For me personally, the only indicator that I could also rely on is that the hospital stopped receiving patients infected with COVID-19. And in fact, this in line with the number being dropping down in the curve, because one of the hospitals in Egypt has closed its door because they are no longer receiving any patient with COVID-19. Also, my colleagues who are working in the isolation hospitals, they said to me, within like 2 or 3 days, I haven't received any patient coming for CT scan or suspect of COVID-19. So the number could be doubled or even tripled, but the case is reflecting on this number that we are kind of in a stable situation. I don't want it to be pessimistic. It could be the end of first wave and there is second wave, I don't know, but the current situation in Egypt that are in a stable phase, and the R0 has decreased. R0 means the number of new cases that could be infected from patient with coronavirus or COVID-19. So it has been decreased from the start of the pandemic, and this is also a good indicator. So what I'm doing during the pandemic, I was supposed to work on research projects or improving my teaching skills to educate my students, but actually I was just like Tom Cruise in Mission Impossible, working on the keyboard, trying to hunt down everyone who comes with false information or hoaxes, and telling people that just because you drink hot water, you can get rid of the virus and he will not get an entrance to your lungs. And just because you keep bleach by your side, that will protect you from getting infected. And actually we have very, very bad situations for those who are very restrictive in using the disinfectant and the bleaches and those with burns from drinking bleach. And there's horror stories about that. So most of the time I was fighting back these rumors and hoaxes, because I felt this is my responsibility to educate and raise awareness among the public. To my surprise, the scientific information or the truth do not spread as fast as the bad information. When I post anything that has related to correcting some misconceptions, it just shared like 1 or 2 times, but those who write about the hot water and the bleach get like 1,000 likes and hundreds of shares. However, before the shutdown, and I had the chance, and I was very happy to educate the public about the coronavirus in February 18th. And at that time, the name of SARS-CoV-2 was novel coronavirus. There was a little information known at that time, so I had to invite Professor Ali Zaki. He's a prominent virologist and internationally known, to speak about the virus aspect, and also Professor Wafa Khalil about the infection control. The reason I invited Professor Ali Zaki, because he was the one who identified MERS-CoV. It's a cousin of the current coronavirus in Saudi Arabia, and announcing this discovery cost him his job. He was fired from Saudi Arabia after 20 years of work because he announced the emergence of this new virus. He has a very interesting story. It's not the time or place to talk about, but if you like to learn more about his story and the conflict between researchers and government in health security, you can read about Professor Ali Zaki. So what are the public views of COVID-19? It's just like the picture says. There's people who are actually into following the guidelines and very strict about using the mask, the hand hygiene, and those who are feeling that it's conspiracy theory. It's virus, man-made virus. So those who released it, they will just take it away from us in no time, and but after making a large profit from the vaccines and disinfectants and so forth. So people actually, I realized in my community that who believe that this is a man-made virus are the most reluctant in using the masks or following the hygiene measures as instructed by Ministry of Health or WHO. And those who believe that this is a natural virus are really keen to use the mask and follow the protocols as stated. So we have this not only in the public, but even in the families. You can find a member who would clean the hands every 5 minutes, and someone who just don't care about it and just go out in the street without a mask or anything. Of course, the lockdown has ended on June 27th, and we started to face a new phase of new normal. Some people think that since the government announced the end of lockdown, that means the virus is no longer exists. So going down to the streets right now in Egypt, we will find so many people not wearing their mask, or even wear it, but in a wrong way. And they kind of feeling the freedom. So they start to neglect the hygienic measures that used to. However, as much as we can, some people still believe in the virus and respect the social distancing. This is a funeral of a COVID-19 patient. This is in the mosque. This is a very creative wedding invitation using the mask. I like this idea. And in celebration of Eid, this is a new face of Eid where the ladies are wearing masks and gloves to make the cookies of the Eid. Okay, so what are the lessons learned? This is from my own personal perspective. This is me looking at the big picture. One of the things that I think it's crucial and it's a priority for all countries, not only Egypt, is mapping out existing capacity. You need to know what you have and what you do not have in order to better your planning and response. And I'll give you a funny story about that. I was called for a mission with WHO emergency to one of the countries. And the mission was to combat the cholera outbreak that was prevalent in this country. And my terms of reference was to train the bacteriologists there how to identify Vibrio cholerae, how to detect their susceptibility and sampling and so forth. And to my surprise, and to keep the long story short, and it was a very long story for 3 weeks, I found out that these governorates that were hit by Vibrio cholera, they don't have a single bacteriology lab. So I came all the way from Egypt to tell the people who were hit by the cholera, you actually do not have a single bacteriology lab in your governorate, and you, because you're relying on one of the biggest labs, like Central Public Health Lab in your country, you didn't have time to see if you have different capacity that can help take the burden out of the Central Public Health Lab. In most of the country, I can see the attention is always drawn to Central Public Health Laboratory or the National Reference Lab, which is good. But we need to know that at time of emergency, at time of upsurging of cases, you would need also additional support from other laboratories in different governorates. You cannot put all the pressure on the one lab. So it was no labs there, and they have been hit by this outbreak for several times, and they didn't have the time to go through the laboratories and see what's in there and which one can help the big lab to perform its function. And of course, the mission turned from just training the laboratorians into assessing the capacity to see which lab can function as a bacteriology lab. I have to say, mapping out existing capacity doesn't require any resources. Actually, it will save a lot of resources. I assessed like 27 laboratories in almost 5 days with a car and a paper and pen, and it's myself. And to be honest, saving resources would help you when you plan for preparedness and response to any emergencies. You will be in the right track. Some people also go for consultants overseas and pay a lot of money while they have a better expertise in their countries, but they don't have time to find them, to seek their help. And so I constantly present that mapping out existing capacity is not only important for health security, it's important for different aspects of emergencies. And so this was lesson learned. I hope Egypt, like other countries, would go and see what they have, what they don't have by the end of this pandemic. So if, God forbid, a second wave hit us or any emergency, we would know that we would not advise the patients to go to a hospital and they find the ventilator is not working. We do not go to a place that the doctors are not trained to using PPEs and they got infected and die. So existing capacity has to be mapped out. They should have a database, and they should update this database. I don't want a 10 years old database, and so when I go for a response plan, I would not find the same information as it was in 10 years ago. One thing also is understanding the level of awareness and education in your country. You need to understand the culture, the level of awareness, and based on that, you impose the measures. In a sleepless city like Cairo, you would expect that partial curfew would not be very helpful at the beginning of the pandemic. The total lockdown would be more beneficial because people, once they be in the street, they kind of mix and mingle, and they will not forget everything about the hygienic measure, which will lead to the spread of the virus. So that's why people would, in the social media, was also asking for a complete lockdown for 2 weeks, then this will help to improve the situation of the spreading of the virus. Looking at the death rate between among the healthcare providers would require more investigation to see why this is happening. This was a shortage of the PPEs, that because healthcare workers need more training on IPC, infection prevention and control, because in many countries I have seen that once the doctor received the training, they never received once more, and everything is forgotten. And this is unprecedented situation. We need to have more simulation exercises, so when any time a second wave hit or any emergent virus comes, we know exactly that these people are trained and can do a perfect job in protecting themselves and protecting their patients. Finally, to wrap up, looking at the big picture of the whole pandemic situation in Egypt, I can see that healthcare workers are the best in this experience. They were so dedicated. They work with very limited resources. They were maybe in many places, especially in the distant government, they were maybe untrained, but they've done a tremendous job trying to work under these circumstances and help to contain the virus and provide treatment for their patients. Of course, the bad thing about the whole thing was the rumor and hoaxes. I had a different view for some people now, because I felt that these scientists who spread the rumors and hoaxes need to be re-educated again. The nonsense they were spreading on Facebook was unbelievable. So I think this was the bad aspect of the whole the pandemic thing. Of course, I've talked about my experience about the mapping out the capacities and the laboratories, but I have to say this underlines that the biosafety and biosecurity needs more attention, and not in the big laboratories. There are distant laboratories where you don't know what's in there, so you will not be able to secure it. And that's why, as we move from the big laboratories, we can also work with these small laboratories, because the threat could come from these laboratories who would not be trained well. They do not know anything about the sense of biosecurity. So a threat could be, there could be a source of a great threat. Last thing to say that this is my team in the medical laboratories. We are 95% females holding master's and PhD degree, and 5% are males, and we are planning to kick them out soon, inshallah. Thank you so much for your attention. I hope I made it right to the time. Thank you all.
Perfect, thank you.
Thank you, Margarita. Thank you, Muna, for this speech. It was really great, and I learned more about Egypt's response to COVID-19. So I hope you are all safe, and it is my pleasure to share with you an overview on Mali COVID-19 response. As Margarita and Pilch introduced me before, I think I will skip that part, but I worked at the National Institute of Public Health Research, the structure in charge of COVID-19 response coordination in Mali. So there I am a security and safety assistant to the National COVID-19 Crisis Committee. So I can start my presentation without to be sincerely grateful to this wonderful CRDF Global one-year program on biosecurity and non-proliferation funded by the Biosecurity Engagement Program. So thanks to this program, I get more expertise and knowledge related to biosecurity and biosafety. And this program impacted positively my professional development and give me opportunity to strengthen my health sector here in terms of biosecurity and biosafety. So here, Mali talk related to Mali situation. We are located in West Africa with an area of over 1 million square kilometers. We share 7,200 kilometers with 7 border countries, mean Algeria, Niger, Burkina Faso, Cote d'Ivoire, Guinea-Conakry, and Senegal and Mauritania. All those countries are affected by COVID-19 too. So the capital of Mali, Bamako, has more than 2 million inhabitants. It is also the epicenter of the disease now. So as we can see, more of population are here in the south. The north, this part is under non-state actor occupation. So related to public health challenges here, Mali allocates less than 7% of its national budget to health, which is far from the minimum of the 15% recommended by the WHO. So in terms of public and community health sector workforce, we had from 2018 data, 18,440 agents, of which women represent 48%. So with the range of qualified health personnel, the current ratio is less than 6 health workers per 10,000 inhabitants, far below 23 per 10,000 according to the WHO standard. This low ratio at the national level is also distributed unevenly to the detriment of the northern and central area. So we are challenging also by emerging and re-emerging diseases. Then on March 24, Mali notified its first 2 suspected cases of COVID-19 from 2 regions, Koulikoro and Cairo. So when samples were tested positive to COVID-19 by university clinical research labs, the Ministry of Health and Social Affairs declared the epidemic to the disease to COVID-19 on March 25. We have a weakness also to respond capacity related to capacity to public health emergency, including malnutrition. With this pandemic also, childhood vaccination is very affected because of fake news on COVID-19 vaccine trial in Mali. As you know, this fake news make a difference and was across all African countries, and people feel bad because of that. So we do use many in terms of official distribution of pandemic national information. We do use many ways. For example, to avoid fake news. For example, the daily written press of the Ministry of Health and Social Affairs. This one is very shared by social media and by the national TV too. So from that, people can get the right number of cases related to disease. There is the publication also of a COVID-19 situation report twice a week. Most of data I will present below are from its slides version. The COVID-19 National Coordination, Professor Akori Ignat sometimes did press release to inform the population regarding the response to COVID-19. There is also the National COVID-19 Crisis Committee meeting twice a week. That is one of most important national platform with multi-sectoral approach, with partners' participation and updates to update data and share official information on activities related to COVID-19 response. So here is a picture during a meeting of the committee crisis. Good. So at the start of the pandemic to yesterday, today data publication is not yet ready. We can see that we have 2,453 cumulative confirmed cases. That included imported cases too. Also, we have 1,764 cumulative healings and around cure rates of 70%. We have this has 121 deaths representing an overall mortality of 5%. So from the last COVID-19 situation report, the capitals Bamako and Tombouctou are the most part of the country we have many cases of COVID-19. But here, Tombouctou has many cases because of the presence of diagnosis mobile lab. But now the cases there is going down. Here, we have the distribution of confirmed cases. We can see a non-linear progression of positive cases here in blue, and the red, the diff, percentage of diff. And then the number of positive cases can suddenly increase or decrease overnight. The explication that I found for that is maybe that can be due to the fact that samples are taken from patient own initiative. And also, however, in the country there are efforts are made, however, there is a systematic passenger sample collection from the airport. So we still have special flights such as the International Organization of Migration one out through the border are officially closed until now. From the last situation report, always, the last, the affected age group is 30 to 44, so young people. So, and then the age ratio, we can see that we have more male than female exposed to that get the disease. So moved If you move in laboratory diagnosis size, the laboratory are very important in this period of pandemic response. So now we have more than 18,699 samples tested across the country by 4 labs using RT-PCR. So all those labs are coordinated by the National Institute of Public Health Laboratory. We have also has laboratory, a collaborating laboratory for COVID-19 sample testing. Here, the university, clinical research center labs, the labs from the center, the CICM lab, CICM, Centre d'Infectiologie Charles Murieux, and also the Biological Molecular Applied Laboratory. Those 4 laboratories have capacity and resources to test the diagnosed COVID-19 sample across the country. But also we have mobile lab deployed to Tombouctou region that play a key role in terms of diagnosis in this region. So what about my involvement in the COVID-19 response? So from my department, the big activity was the risk assessment of 52 laboratories in COVID-19 context according to the One Health approach across the country. This was following with the training of lab technicians. We did also under the crisis committee, infection and prevention committee, a subcommittee, a training of trainer of agents in charge of contact tracing. We share them here the safety behavior during their work. So if they went into family and in the community for tracing contact, they have to be careful and use in need, how to use in need physical distancing, hand washing, and also if they use PPE, how to destroy them or keep them, back them to the healthcare for its then normal community people couldn't use it. So let's talk a little bit on lab risk assessment, which covered 8 components. So this is, as I said before, this is one of our department big activity during this crisis, the sanitary crisis. So what we did, we adapted different evaluation sheets from the WHO, from some country, to adapt them to our own context, because the response to COVID-19, this pandemic, is not the same in each country. Each country have its own reality, and I have to work on that. So we work through 8 components to assess laboratories from reference center in the capital, in also isolation hospital, and so on. It was the assessment was on the structure description first, laboratory basic procedure, biosafety practice used in the labs, human resources, available human resources, and also the security measure in biological substance, waste management, biological risk assessments, and a specific point of labs capability to respond COVID-19 in terms of qualified workforce, physical distancing, respect, availability, and use of PPE, hand washing device availability, training of lab technician, and so on. So it was a good experience during this a sanitary crisis, and even with a government effort to respond to the pandemic, what we can say, most people don't believe disease even exists. This explains the lack of physical distancing, respect in the community, and the wearing of masks by normal population. From 52 labs risk assessment, we found that 41 labs respect physical distancing against 21 here, and also related to training of the correct use of PPE, we found that 19 labs were trained to PPE use against 33 labs. That is up to May 14 during the COVID, during the crisis. So what we should do to be more or better prepared to respond to the pandemic here in Mali. Even if our 2 first cases were completely cured before the pandemic declaration in Mali, we should do on January strict respect of full respect of the recommended prevention procedure, and the strengthening of surveillance at the port of entry, traveler lockdown, mostly traveler from airports, and the use of the incident management system to coordinate the response. Also, we should do the mapping of resources, so human resources, material and financial resources, and if you can go back, we will do more communication to raise population awareness on the disease. So, despite of efforts made by the government, partners and donors, we still have gap. So below we have some recommendation. I mean, if you want to improve our healthcare system to respond to COVID-19, you have to ensure regular and sufficient supply of PPE and sample collection and diagnostic kits. Increase of screening, diagnosis and treatment of positive cases. Strengthen communication, that is important. Strengthening screening and contact tracing at the community level. Raise population awareness of the disease transmission mode and the prevention procedure to avoid it. We have to, if possible, decentralize response activity at the regional, district and community level. Then each region will take definitely and deeply part of the COVID-19 response. So what could be the impact of the recent political crisis on COVID-19 response? Big question. Since 2012, Mali is dealing with asymmetric political crisis at the north of the country, where 23% of health facilities are not functional. Just from last Friday, the situation becomes worse in the capital here. The concern of country COVID-19 response. We can believe me, this is more challenging to the fight against COVID-19 regarding to, because we have the circulation restriction, protesters exposed to the COVID-19, who can tell them in this situation to respect physical distanciation. And we have a limited access also to healthcare. And then, so sometimes in front of this situation, I ask myself, for how long this situation in my country? And should we care healthcare attacks by protesters? Nobody knows. But because they attack some official institution of the government. that is a big challenge in front of a normal COVID-19 response challenge. What I learned as personal lesson, I learned that whatever happens, we have to first of all be mentally prepared and ready to serve. Resources could be never enough in our specific context here in Mali. So again, we have to be ready for our community and our country. And sometimes only your passion to work will guide you to overcome challenges. So thank you for your attention.
This is Jill Lester again. I want to thank both you and Mona for your presentations, but I also want to thank you for your time preparing these presentations, your willingness to share your perspectives with us, and for the important work that you are both doing. We really appreciate it. I'd like to remind the audience that if you would like to post a question, you could put it in the question and answer box at the bottom of your screens, or if you would like to ask a question in chat, we will try to get to you that way as well. So I'll just go ahead and jump right into the questions. This one is for both speakers. From your perspectives, could you please comment on how regional coordination has worked during the pandemic? Are neighboring countries working well together and sharing information and or resources? Has the African CDC been an important resource? And what could be improved on for the future? Thanks. Maybe Mona, you would like to go first?
Yes, at the regional level, I think from also my previous work with building capacities and surveillance in both Egypt and countries, I think we have a problem with information in general. The accessibility to information at the national level is very challenging. So I assume that sharing information between the countries would be even more challenging. Each country thinks that it's right to keep the information that may negatively impact the economy, the tourism. And so I haven't seen this kind of sharing information before in surveillance, and I definitely haven't seen this at the level of the pandemic. I think also maybe it's because each country was complacent just announcing the number of cases, and that's huge, by the way. Before that, we used to conceal the number of infection rate, but now we had to, because this is a global pandemic and we cannot hide the numbers, because this will be reflected on the support that can be provided by the international organization. But I think in my position, I haven't sensed that there's kind of coordination and I hope it would be improved. But the first thing, the countries need to believe that sharing information is not a bad thing, because it will spares funding, spares more coordination at different level. Maybe would share the challenges, and some country would have a solution we don't have. So this is my perspective for the whole thing. But, thank you. Over to you.
Thanks. Kadi, would you like to respond?
Yep. So here, there was also a communication between countries in terms of sharing data and information, because when the border were closed, people were traveling across the West Africa here and across the world. Then it was a big deal at the beginning, but at the time, in terms of activities and so on, people and government start to share communication, to share data. And also we have now in Mali a support of CDC Africa. Consultants are here to support them on how to strengthen our response system to COVID-19. So there is a strong coordination, collaboration with border countries here. Thank you.
Thank you. And Mona, during your presentation, you mentioned that the World Health Organization has been helpful and a great resource. Are there other international organizations that have been helpful or a good resource, or not as much as the WHO? I think you're on mute.
Yeah, maybe because I was in a close relationship with the USAID support during working at number 3, so I keep up with the updates, and they have been also a great support during the pandemic. That's what I heard about the contribution of World Health Organization and USAID. But I'm sure there must be others that maybe will not gain the visibility as it should be. But I think there is much more support maybe for European Union, because this was actually great deal for us. The molecular testing and the PCR testing required a lot of resources to be able to contact tracing and confirm the suspected cases with COVID-19. So I'm sure there was other organization maybe I'm not aware of that have provided support to Egypt with this regard. Over to you.
Great, thank you. Katie, how about you, or from your perspective? Well, I think you're on mute. Katie, I think you're on mute.
It's okay now?
Yes, thanks.
Yes, okay. I said here, the government work closely with some partners and donors. We get help from the World Bank, UNICEF, WHO, USAID, as I said before, the African CDC, some donation from China, and now we are waiting for Japan donation. So we get this help and we are working together. For example, WHO and USAID staff attend to our committee crisis meeting anytime. So we are working together, doing activity, planning activity together, and so on.
Thanks. A question, Mona already answered it, but it came into the Q&A. The question is, people see death from COVID-19 as a stigma. Is that a problem in Mali? Mona mentioned that it is the same in Egypt. I don't know if you want to elaborate on that, Mona.
We had the extremes in response to being infected with COVID-19. We have neighbors who block the streets, not allowing those who are infected to get entrance to their buildings. And we have neighbors who provide food at the door of people and the families of infected. So we never have, we have different situations, depends on the mentality and the mindset of people. And to be honest, I have seen scientists also behave the same, though I thought that it would be only in people who are not educated, but unfortunately this is totally different situation. I have to say also, in cases doctors were appraised for their work and people were clapping their hands when they coming, and others prevent the doctors and even their daughters to go to schools or to seek medical advice in places. So it was a horrific situation, and it's actually requires more social investigation how this is happening and why this discrimination between the reaction and behavior of people. Over to you, Kadi.
So here at the beginning, it was really hard to people to understand about COVID-19. If you say that people had get sick of COVID-19, there was a stigma from the community, a stigma. But now I think they start to understand. Even some people don't trust that this pandemic is true. So with deaths in families, in community, and also with more deaths in our in Timbuktu region, people start to trust. But political situation may give to people different thinking on the pandemic existence here. So because we did our election, legislative election here, and deputation election, and also now there is a crisis in the center. Because of that, people said pandemic is not true, and even there is some who trust to the disease. But for example, hearing a mask in the community, you will look like someone different. So the stigma is here from people in community who trust the disease, but in other sides, they don't care the disease. That is the fact here.
Thank you. A question for both of you from Eduardo Sanchez. Using a multilateral approach, could some innovative avenues be explored for future preparedness and rapid response to pandemics, such as the biosecurity requirements of the 1540 resolution of the UN Security Council? From your perspective.
Oh, that's a bit challenging question for me. I remember 1540 resolution when at the time I was in MIS. I'm sure I haven't visited this before, but let me answer in general. Maybe this will help, or maybe I'll come back with a different answer later when I dig back in the 1540 resolution. In general, in Egypt, I'm talking from the lab aspect, the biosecurity aspect is totally neglected. It's unknown term. And I have to be honest, before joining CNS and MIS, I was confined to my lab work and never thought there is a whole world beyond working with pathogens in the lab. And this was an eye-opening experience for me. That's why when I came with the capstone project with Biosafety and Biosecurity, to try to engage that term in the routine work of laboratories. But still, there is much work ahead because people are just going to work. People would tell you, it's enough for me to take care of myself, to protect myself. I'm not, I don't have the time or the capacity to protect my pathogens. And they do not think that there is a threat or theft or misuse or dual use or whatever they think. So I'm sure this is not the answer of your questions, but for my country, I think we still need to work more and put more emphasis on the biosecurity or to secure anything that would lead to any threat or to endanger our community or society. If it is aligned with 1540 resolution, that would be great, but I think it will be a difficult path because we need to convince the people first and raise their awareness about this whole world beyond the small laboratories, the small thing, the scale that they are working on. I'll come back with a better answer maybe later.
No, that was great. Thank you. Katie?
So I have to mute the video to microphone because of network availability. So that is a good question in my context. I really appreciate it. Here we are under non-state actor control in our nerve, right? And in the center, we do have another crisis politic. So that allow time and opportunity to non-state actors to act. If you see the 1540 Resolution Council, what they said, that countries have to take regulation for non-proliferation of all kinds of weapons of mass destruction, biological agents, chemical agents, and nuclear agents. So this pandemic show that what COVID is here, the propagation, community propagation is easy and speed, right? And non-state actor, if they get chance and opportunity to use this, nobody can say that they will not do, even if they will not do that here in Mali. But it is a really threat for us. And we have to overcome that by strengthening our national regulation related to biosecurity and biosafety. I think that efforts are being made on this field. There are some projects that help Mali, the Public Health Agency of Canada with the Malian Biosafety and Biosecurity Association and the Ministry of Health are really working on how to strengthen Mali national regulation in terms of biosecurity and biosafety with a multi-sectoral approach. I mean, health sector, human health and animal health, environmental sector, all together to strengthen national regulation related to biosecurity and biosafety. And also from the joint external evaluation here, it was a recommendation to us to strengthen our tools, our related to biosecurity and biosafety, to do to build a program, a national program, evaluation of risk program in the country to train and so on. So the resolution 1540 have to be more considered in Mali.
Thank you.
And I think its implementation, its full implementation will help us.
Thanks. I want to be respectful of everyone's time, but we do have one last question here for Katie and maybe Rich. Rich advocated for a more centralized response in the US, and Katie suggested an opposite through decentralization. Could you explain further why the opposite suggestions? And Mona, if you want to comment, you may too.
So, Katie, I'll just go first here. And first of all, I appreciate the opportunity to speak again. This has been great. What I was trying to get across is the need for a central coordinating authority, and that's different from a centralized response. In the US, we don't want to be sending every sample to the CDC to be analyzed. We can't do that. They don't have the throughput capacity. So we need to distribute that testing capability out. And it is distributed. It's run by the state public health departments and their surge capacity. But what we do need is a central authority that is dictating how the testing is administered, how the contact tracing is administered, and providing surge support when necessary. I would guess that Katie's point is the same thing. They're having a political crisis in their capital city, and there isn't the ability to bring the problem of COVID-19 from the regions to the central city. They need a capability in the regions to be able to manage the event. But I don't think she means that that the government in their capital city should not be providing the central coordinating authority of those activities.
Katie, did you want to comment as well?
So in this situation, for sure, if we could decentralize the response to COVID by giving opportunity and materials to regions to respond and to test themselves simple, that will be very helpful. But until now, all things are testing diagnosis were due in the capital. We have here in the capital labs in charge of COVID-19 diagnosis. So yes, if you can help regions to do themselves COVID tests, that would be very, very, very impactful. But from our risk assessment, hospital, we have an hospital by regions. All hospital can't do that because of safety and because of their level of security and safety and the presence of the lack of, I would say the lack of a procedure there. They are not, all regions are not ready yet to do that, to do the COVID-19 test. But they send sample to the country. How do they do? They do that safely, and it is under technician control. People who know how they ship. Those people send a sample to the central to be testing and confirming. But we still have also weaknesses in this field. Shipping sample across the country, you have to be careful. You have to work with trusting people. You have to know who, from where to where sample will go through before coming into the capital. So we do have weaknesses, but we are working on it with partners, with donors, and I hope that we are open also to all collaboration, and even we know now we are dealing with COVID-19, but we don't know what this disease will impact our workforce, our health system, and our behavior later. So thank you.
Thank you to both of you. I know I certainly learned a lot today. I, again, want to be respectful of everybody's time, and I know we've run over a little bit. I don't know if I would welcome final remarks from Rich or Margarita, if you wanted to say anything.
Just very quickly, I want to thank Mona and Katie for investing so much time and effort in this exceptional presentations. What I take away with me is that I am so proud of what we could offer to actually, you know, people like Mona and Katie who come to our center with a wealth of technical expertise, and we help maybe, you know, have the modest contribution to get them out of their comfort zone, what Mona said, which I really liked, of their expertise, and maybe expand, you know, the picture and show how their scientific knowledge has also security implications. And I think these presentations, they demonstrated how both of our speakers were able to, you know, as experts in their fields, they also were able to address and tackle issues which relate to general, more wider security implications. I think that is an incredible synergy between science and policy, which I think, you know, constitutes our field. So I think that that's just something that I wanted to make this observation in the conclusion of this.
Yeah, thanks, Margarita. I'll take the opportunity to speak one more time. You know, and I would extend that to the benefits that we get from working with Mona and Katie and all of the other fellows, and how it enriches our understanding of you know, the way that we can work together to address these you know, big problems, whether it's climate change or industrial farming that's leading to exposures to new viruses, or, you know, the list goes on, and these are major international problems that in the US we don't necessarily understand because we don't deal with them on a day-to-day basis. I would just draw attention to sort of two things that jumped out at me during the presentation, during the presentations, and that's two big things I don't think I wouldn't have predicted about this pandemic that are happening in the US and also happening in Egypt and Mali. Is one, there is a tension between public health and politics. And, you know, I think that's a very, very valuable lesson as we prepare for the future. And the second is the influence of social media and hoaxes and how that is really impacting everything. I know those are sort of obvious to all of us going through this together, but not something I think we were ready to deal with, and something I think we're going to have to think very hard about moving forward. So again, I'm honored to be a part of the group on this presentation. I think Mona and Katie and Margarita and Jill, it's been great. I've learned a lot, and thank you for all the viewers.